Beta blockers, mechanism, adverse effects, and uses. Imagine you're treating a 24-year-old man with hypertension who also has a history of asthma. You prescribe a beta blocker to control his blood pressure. Within hours, he develops severe wheezing and breathlessness. What went wrong? Why can one beta blocker trigger bronchospasm while another can usually be given safely in the same patient? The answer lies in understanding beta receptor selectivity and the pharmacology of beta blockers. What are beta blockers? Beta blockers, also known as beta adrenergic receptor antagonists, block the effects of adrenaline and noradrenaline on beta adrenergic receptors throughout the body. By preventing these stress hormones from activating beta receptors, they reduce sympathetic stimulation. There are two clinically important beta receptors. Beta 1 receptors are found primarily in the heart. Beta 2 receptors are located mainly in the lungs and blood vessels. Based on receptor selectivity and pharmacological properties, beta blockers are classified into three generations. Understanding these generations is important because they differ in receptor selectivity, additional actions, adverse effects, and clinical uses. First generation, non-selective. The first generation beta blockers are called non-selective because they block both beta 1 receptors in the heart and beta 2 receptors in the lungs and blood vessels almost equally. Blocking beta 1 receptors produces the desired cardiovascular effects such as reducing heart rate, myocardial contractility, and blood pressure. However, blocking beta 2 receptors is responsible for bronchoconstriction. Therefore, these drugs should generally be avoided in patients with asthma or COPD as they may precipitate severe bronchospasm. The prototype drug of this generation is propranolol, which is also the most commonly studied non-selective beta blocker. Other important examples include timolol, nadolol, and pindolol. Second generation, beta 1 selective or cardioselective. Second generation cardioselective beta blockers were developed to minimize pulmonary side effects by targeting beta 1 receptors in the heart much more specifically than beta 2 receptors in the lungs. As a result, these drugs effectively lower blood pressure and heart rate while producing less effect on the lungs, making them a better choice for patients with hypertension or ischemic heart disease who also have mild asthma or COPD. However, there is one important limitation to remember. Their selectivity is dose dependent. At higher doses, they begin to block beta 2 receptors as well, so the advantage of cardioselectivity is gradually lost, and bronchoconstriction may still occur. The important examples in this group are metoprolol, atenolol, bisoprolol, acebutolol, and esmolol. It is important to remember that these drugs are beta 1 selective rather than beta 1 specific. They preferentially block beta 1 receptors, but this selectivity is not absolute, especially at high doses. Third generation, vasodilatory beta blockers. These drugs not only block beta receptors, but also relax blood vessels, producing additional vasodilation. Because of this dual action, they provide more effective blood pressure reduction. These drugs produce vasodilation by two different mechanisms. The first is alpha-1 blockade. By blocking alpha-1 receptors in vascular smooth muscle, they directly relax blood vessels and reduce peripheral vascular resistance. The important examples are carvedilol and labetalol. The second mechanism is nitric oxide release. Nebivolol stimulates endothelial nitric oxide production, leading to relaxation of blood vessels without alpha-1 blockade. This additional vasodilatory effect improves blood flow while maintaining the beneficial cardiac effects of beta blockade. They are also associated with better metabolic profiles and antioxidant properties compared with older beta blockers. Generations at a glance. Let's quickly review the three generations of beta blockers. Each generation was developed to improve on the limitations of the last, reducing pulmonary side effects and adding vascular benefits. The first generation beta blockers are non-selective. They block both beta 1 and beta 2 receptors, making them effective cardiovascular drugs, but their broad blockade increases the risk of bronchoconstriction, especially in patients with asthma or COPD. The second generation beta blockers are beta 1 selective or cardioselective. By targeting the heart preferentially, they produce the desired reduction in heart rate and blood pressure with less effect on the lungs, making them relatively safer in patients with mild obstructive airway disease. However, remember that this selectivity is dose dependent. The third generation beta blockers retain the benefits of beta blockade while adding vasodilation through alpha 1 blockade or nitric oxide release. As a result, they not only lower blood pressure effectively, but also have a better metabolic profile. Side effects. Let's begin with the cardiac adverse effects. Excessive beta 1 blockade can cause bradycardia and even heart block, particularly in patients with underlying conduction abnormalities. Another important point is rebound hypertension or angina following sudden withdrawal. Therefore, beta blockers should always be tapered gradually, not stopped suddenly. Next are the respiratory adverse effects. Bronchospasm occurs mainly with non-selective beta blockers because they block beta 2 receptors in the bronchi, leading to bronchoconstriction. This is why non-selective beta blockers should generally be avoided in patients with asthma or COPD. Finally, the metabolic and other adverse effects. Beta blockers can mask the symptoms of hypoglycemia, especially tachycardia and tremors, making hypoglycemia more difficult to recognize in diabetic patients receiving insulin or sulfonylureas. Other commonly reported adverse effects include fatigue, cold extremities due to reduced peripheral blood flow, erectile dysfunction, depression, and sleep disturbances, particularly with lipid-soluble beta blockers such as propranolol. Cardiovascular uses. The first indication is hypertension. Beta blockers lower blood pressure by reducing heart rate and cardiac output. Although they are often second-line therapy in uncomplicated hypertension, they remain valuable in patients with coexisting ischemic heart disease, heart failure, or certain arrhythmias. The second use is angina pectoris. By slowing the heart rate and reducing myocardial contractility, beta blockers reduce the heart's oxygen demand. This improves exercise tolerance. A particularly important indication is post-myocardial infarction or post-MI. Beta blockers have been proven to reduce mortality after a heart attack by decreasing the risk of recurrent myocardial infarction, ventricular arrhythmias, and sudden cardiac death. They also play a key role in heart failure. Selected beta blockers, bisoprolol, carvedilol, and metoprolol succinate, improve long-term cardiac function, reduce hospitalizations, and significantly improve survival in patients with chronic heart failure. Finally, beta blockers are widely used in arrhythmias, particularly for heart rate control in atrial fibrillation. By slowing conduction through the AV node, they help control the ventricular rate and improve symptoms. Beyond the heart, Other clinical uses. Let's begin with glaucoma. Timolol eye drops reduce aqueous humor production by the ciliary body, thereby lowering intraocular pressure. This makes timolol an important drug in the treatment of open-angle glaucoma. The second indication is migraine prophylaxis. Beta blockers, such as propranolol, are used as preventive treatment in patients with recurrent migraines. They reduce the frequency and severity of attacks, although they are not useful for treating an acute migraine episode. Next is thyrotoxicosis, particularly in Graves' disease. Beta blockers rapidly relieve symptoms such as tachycardia, palpitations, tremors, and anxiety by blocking excessive sympathetic activity. Finally, beta blockers are highly effective in essential tremor. Propranolol reduces the amplitude of the tremor, improving daily activities such as writing, eating, and holding objects. Critical warning: never stop abruptly. Like clonidine, long-term beta blocker therapy causes upregulation of beta receptors. If the drug is suddenly withdrawn, these extra receptors are exposed to circulating adrenaline and noradrenaline, resulting in excessive sympathetic stimulation. The first consequence is rebound hypertension, where blood pressure rises sharply after discontinuation. Even more dangerous is unstable angina, as the sudden increase in heart rate and myocardial oxygen demand can precipitate myocardial ischemia or even an acute myocardial infarction in susceptible patients. Therefore, whenever beta blockers need to be discontinued, the dose should be reduced gradually rather than stopped suddenly.